Welcome, everybody. It's so nice to have such a good group of people from all over the world. I'm going to just say a little bit about the IUHPE in case any of you are not members. The International Union for Health Promotion and Education, or the IUHPE, is a global professional, non-governmental organization dedicated to health promotion around the world. It is committed to improving the health and well-being of people through education, community action, and the development of healthy public policy. Recognizing that health is a basic need and a human right, the IUHP supports actions that empower people to control their own health and that promotes healthy societies. Now, before we begin, I want to mention, in case you're not aware, that the IUHPE every 3 years has a global conference. Our next global conference is coming up next year from the 15th to the 19th of May. It's a hybrid conference, so it will be physically taking place in Montreal, Canada, but you also have an opportunity to join virtually, and there are 2 different registration fees depending upon whether you will be there in person or virtually. I want to also mention that the IUHP has 7 what we call global working groups, and they're groups comprised of experts that serve to contribute to the scientific agenda of the union and thereby help to develop the knowledge base and better practices in health promotion that get shared all over the world. My name is Marilyn Rice, and I have the privilege of chairing the IUHP Global Working Group on Healthy Settings. It is the group that's sponsoring our webinar today in celebration of the IUHPE's 70th anniversary. We acknowledge that what's become known as settings, or a settings-based approach, is based upon the recognition that the contexts or places in which people live their lives are critically important in determining health. We understand that a setting for health is a place or a social context in which people engage in daily activities in which environmental, organizational, and personal factors interact to affect the health and well-being of the whole population. This setting may be geographic or it may be virtual, and a lot of what's happening today, especially with COVID, is taking place through virtual communities. Due to the complexity of creating conditions for people to be healthy, the healthy settings approach implies working through comprehensive, integrated programs and settings of everyday life. It takes a systems approach by acknowledging interconnectedness, interdependency, and synergy among different components, while recognizing that each setting is connected to the world around it. And it appreciates that most settings do not have health as their main mission, and it is therefore essential to advocate for health in terms of the impact it will have on the core business of each setting. Our webinar today is focused on how healthy settings can provide opportunities for collective and individual responses to current global challenges. We will have 4 presentations, and then at the end, we will open it up for discussion and questions. So again, as Alexandra said, please pose your questions in the chat. Our first presenter will be Professor Mark Doris, who at the University of Central Lancashire in England is Professor in Health and Sustainability. He is co-director of the Healthy and Sustainable Settings Unit and co-director of the Institute of Citizenship, Society, and Change. With a background in health promotion, public health and community development, and environmental policy, he has worked within the health services and voluntary sectors, as well as with local governments and higher education. Mark is co-chair of the International Health Promoting Universities and Colleges Steering Group, chair of the UK Healthy Universities Network, a member of Universities UK's Mental Health and Higher Education Advisory Group, an expert witness to the Climate Commission for UK Further and Higher Education. From 2007 to 2011, he chaired this Global Working Group on Healthy Settings. And from 2011 to 2014, he was responsible for coordination of the UK Healthy Cities Network. He has published widely and undertaken consultancy work for the WHO and Public Health England on health and all policies, healthy cities, and community participation and sustainable development. Mark will be talking with us today about a cross-cutting overview of the healthy settings approach and how it promotes collective and individual action on current global challenges. Mark.
Hello, I'm delighted to be here, celebrating IUHPE's 70th birthday. The Healthy Settings movement is widely understood to have been kick-started following the Ottawa Charter, which contended that health is created and lived by people within the settings of their everyday life, where they learn, work, play and love. Its importance over the years has been further affirmed in outputs from subsequent global conferences, including the 2016 Shanghai Declaration. So what is the Healthy Settings approach? Reviewing the literature, I'd suggest that it involves a focus on place, people and increasingly planet, and the interrelationships between them. An understanding of settings not only as convenient places to deliver health messages, but also as contexts that directly and indirectly impact well-being, and a commitment to integrating health within the culture, structures, processes and routine life of settings. Addressing the question why, we know that while important, health services are only one factor influencing health, their main focus being illness. We also know that health is determined not only by personal and behavioural factors, but by wider living conditions and socio-economic, political, environmental, commercial and cultural factors. This points to a growing recognition that people's lives and the processes of enabling human flourishing and addressing 21st century health challenges are complex. So if health promotion is to effectively address these interconnected factors and conditions, we need to move beyond a focus on single thread interventions and instead prioritise comprehensive integrated programmes in the contexts of everyday life, where people are born, where they grow, learn, work, play, love, live and die. Moving on, I want to profile a conceptual framework that I first developed in 2006. This argues that the approach is underpinned by core health promotion values and has 5 characteristics. First, it reflects a salutogenic view, concerned not only with illness, but with well-being and what makes people flourish, fostering the health potentials inherent in the social and institutional settings of everyday life. Second, it adopts an eco-social model. It appreciates that health is multi-layered and determined by a complex interaction of factors. It focuses on populations in particular contexts, and it addresses human health within the framework of ecosystem health. Third, it views settings as dynamic, complex systems with inputs, processes, outputs and impacts characterized by unpredictability and feedback. It acknowledges and values the interconnectedness and synergy between different components, and recognizes that settings are nested, each connected to the world about it. Fourth, it adopts a comprehensive holistic change focus, drawing on learning from organisation and community development. It uses whole system thinking and multiple interconnected interventions to embed health and shift cultures in diverse settings. And fifth, it appreciates that most settings do not have health as their main raison d'etre, and that it's therefore essential to translate arguments into language that resonates with decision makers, advocating for health in terms of impact on or outflow from core business. Informed by this conceptual framework, this model explores the question how, what the approach means in practice. It shows how underpinning values come together with priorities and drivers drawn from both public health and the core business of the particular setting to inform action across 3 focus areas: creating healthy and supportive working, learning and living environments, integrating and embedding health and sustainability in the routine life of the setting, whether quality of patient care, education or rehabilitation of offenders, and connecting with and contributing to the well-being and resilience of the wider community. I now want to focus on some of the opportunities and challenges that arise in seeking to implement the Healthy Settings approach in a coherent and effective way, exploring these in terms of connections. First, a holistic and integrated approach means connecting within the setting. This will mean thinking in terms of the whole system and appreciating and mapping linkages that exist and finding ways to knit things together across silos to enhance synergy. To illustrate this with reference to a university, Our focus might be on connecting between different groups of people, different topics or issues, different components of the system, or different policies. When focusing on a connected approach to planning and implementation, it is also important to link this to research and evidence, and there are clear challenges involved in moving beyond the evaluation of individual interventions to capture the added value of a whole system approach. The second and holistic and integrated approach means connecting outwards, appreciating that settings are interlinked. People's lives straddle different settings, both at a specific point in time and across the life course. Similarly, 21st century challenges such as climate change and obesity do not respect boundaries. Furthermore, these boundaries have become increasingly permeable. A problem made manifest in one setting may have its roots in a different setting, which in the case of an issue such as bullying in a school, is increasingly likely to be online as well as within the geographical community. Additionally, looking outwards means appreciating that all too often the disadvantaged and marginalised are not found within the established or formal settings, and that we need to identify the gaps in between. Settings also exist at different levels, often within the context of each other. For example, a hospital may be within a particular neighbourhood, within a city, within a district, within a country, with the planet being the overarching contextual setting. This echoes Bronfenbrenner's work on social ecology, in which he suggests that human development takes place in micro, meso and macro settings within a number of nested layers. This implies a need to view individual settings as part of a bigger whole and work to enhance the synergy between them and maximise their contribution to the well-being of places. While certain WHO regions have at times focused on families of settings within the overarching frameworks offered by healthy cities, healthy districts or healthy islands, the sad reality is that bureaucratic structures and competing egos have too often intervened and stopped this from happening. Third, it means connecting upwards, acknowledging that work in settings is influenced by higher level influences. In looking upwards, we can align our work with the health in all policies perspective, focus on wider determinants of health and inequality, and also prioritise advocacy, using our leverage to call on governments, multinationals and global organisations to act for health sustainability and justice. Finally, it means connecting beyond health, building bridges with policy agendas such as sustainability, climate change, biodiversity, inclusion and social justice, which, though clearly determinants of human and planetary well-being, are too often the focus of programmes that are siloed and separate from health. In concluding, I want to reflect on what we've learned through our collective experience of living with COVID-19. First, it reminds us that effective health promotion requires an integrated approach that appreciates social, economic, cultural and environmental contexts. Although widely termed a pandemic, it is more accurately understood as a syndemic, characterised by the synergistic interaction between biological, social and ecological conditions, and highlighting the need to tackle wider determinants and persistent inequalities in society. Second, it highlights the essentially holistic nature of health. As a communicable disease caused by a pathogen, it affects physical health, but mental health has also been significantly impacted. Furthermore, both physical and mental health effects are in part mediated by social well-being, with the impacts of containment measures influencing patterns of interaction and connectivity. Third, this interplay of influences is played out in the settings of everyday life. COVID-19 has challenged traditional understandings and profoundly disrupted the day-to-day experiences of these settings and required us to navigate our present and our future. Fourth, it spotlights the inextricable connections between human, ecological and planetary health. Widely believed to be caused by a pathogen originating in wildlife, COVID-19 points to the growing threat that zoonoses represent to global public health, a threat symptomatic of our exploitation of nature and an unsustainable food system linked to habitat destruction, biodiversity loss and climate change. And fifth, alongside the suffering, injustice and predicted long-term damage, COVID-19 has offered glimpses of what a new and different world might look like. Lockdowns have been associated with new patterns of working and learning, and with reduced air travel and motor traffic, increased cycling and walking, improved air quality, decreased carbon emissions, and a newfound connectivity with nature. All of this points to the potential for the disruption to serve as a catalyst to the sort of transformative recovery necessary to realise the rhetoric of build back better and fairer. Let's make sure that healthy settings practice helps make this happen.
Thank you so much, Mark. That's a great way to launch our discussions today, giving us the background and framework for us to move forward. Our next panelist is Professor Albert Li, who is at the Chinese University of Hong Kong, where he is currently clinical professor in public health and primary care and founding director of the Center for Health Education and Health Promotion. Albert is a medical doctor with specialized training in family medicine and public health, and he has been awarded fellowships from Royal Colleges in the UK, Australia, and Ireland. He is dedicated to developing primary care and community health promotion through healthy cities, health promoting schools, and healthcare settings. He has over 250 publications in peer-reviewed journals. His work has been recognized by his election to an international member of the National Academy of Medicine in the United States, an honorary fellow to the UK Faculty of Public Health. Since 2003, he has been a consultant for the World Health Organization in health promotion. And in 2014, he was recognized as a pioneer in healthy city research by the Alliance for Healthy Cities. Albert will be sharing with us today the example of how health promoting schools can serve as an avenue to respond to current global challenges.
Thank you, Marty, for the kind introduction, and I'm delighted to have the opportunity to share with you on Health Promoting School to commemorate the 70th anniversary of IUHPE. Within the next 10 minutes, I will try to discuss some of the challenges we are facing with public health emergencies and the impact of COVID on student life, and identify some of the gaps in conventional school health promotion and how we could make use of health promoting school as a framework to change the risk perception and enhance the healthy behaviors. We have been facing a lot of health emergencies. Recently, COVID, but we must not forget other issues such as climate change, air pollution, epidemic NCD, poverty, conflict, social isolation, and marginalization. And if you look at the COVID, it has affected 250 million learners, and students in low-income countries has suffered greatly due to lack of infrastructure, of digitalization, unable to access to teaching and learning. So one important task we have to handle during the recovery phase is to prevent what happened in last century before, to have another mass of young adults growing up with low-level literacy, which has a significant impact on education, economic, and social perspective. Well, we look at student life under COVID. Based on our recent study, we have identified significant proportion of students not only have a drop in the physical activities, but risk in the near future. And similar findings have been observed by my colleagues to study the tertiary students, and nearly 2/3 actually have increased anxiety and stress, and about 30% experience moderate to severe level of depressive symptoms. And those engaged in less outdoor activity, physical activities, increasing use of electronic media, have high level of depressive severity. And you must not forget the fundamental importance of physical activity, healthy diet, having impact on physical and mental health. And we really need to be a little bit more proactive in creating a better living space for focus on the narrow predetermined health outcome of students. We will miss a lot in school health promotion. The Western Healthy School Award Scheme and the Hong Kong Healthy School Award Scheme have developed a detailed system of standard aiming to cover more comprehensive approach and to build up the activity in school which could lead to better health outcome in long run. Well, hygienic measures such as hand washing, hygiene practices, face mask wearing, adequate physical distancing could have an impact on control of outbreak of COVID-19 or other infectious disease. An appropriate level of risk perception will be needed to predict those health behaviors, and the community action is very much needed to deliver the effective health messages meeting the needs of the local circumstances and the comprehensiveness of the local community, to break the barrier, to mobilize local resources and build up the collective action within the community. Health communication is fundamental, and health promoting school could make the communication become not just knowledge transfer, but also contains an element of trustworthy message, sense of volunteerism, and collective action. Health promoting school could be an effective complex intervention to alter health behaviors, because it is not just focusing on one area, it's multifactorial, covering curriculum, physical and social environment, policy, linking with community, plus how to work effectively with the healthcare services. So under different key areas, we could tie in the important components to enhance infection control. Just give you a few examples. For example, some policies on protective measures implementation, the enhancement curriculum, make people have a broad understanding of why the infection control measures should be in place, and protective environment to minimize the harm, but at the same time not to create unnecessary social isolation, and the appropriate linkage with the community and the health services make people understand why people should be isolated, quarantined, or uptake certain measures, to win the community support and appropriate health-seeking behavior. Now, this is a logic model of health promoting school based on Healthy School Award Scheme, and you can go to the paper for the detail. The essential thing is you need to put the infrastructure in place, and through structured activities leading to different levels of outcome, not just the final outcome, different level of outcome driving the changes in long run. We perform a scoping study to update health promoting school to include literature review, documents, recommendations, and some of the guidelines, so we could examine the health promoting school in greater depth to clarify some of the concepts and gaps. With that, together with the 20 core indicators that we have identified to have a significant impact on health-related outcome of students, we could develop a more detailed standards to allow the school to conduct a self-assessment on the perform health promoting school. You're welcome to visit those two papers. They are open access, and you can share and disseminate to your colleagues. During the meeting and recommendation of the knowledge network to the WHO Commission for Social Determinants of Health, one of the important recommendations is healthy setting of vehicles to tackle social determinants of health. And health promoting school could play its vital role, not just have an impact on school, but also on society. have an impact on the hygienic environment, green environment, safe and harmonious environment as a setting for health promotion for staff, have an important vehicle to link with the health service, and also nurturing a group of quality citizens in future.
Probably this is the last PowerPoint. I just really want to summarize that we are aiming just for living well. And I think the healthy setting could play a part. I think I will leave it for the question, and you could share the PowerPoint with the participant later on. Thank you.
Before I introduce the next speaker, I just want to remind everybody to please put yourself on mute and turn your camera off. We'll have a chance at the end to discuss things and share ideas. Our next speaker is Irma Brito, who was born in Angola, but now she lives in Coimbra, Portugal. She is a teacher and researcher in the Nursing School of Coimbra, specializing in community nursing. She is a leader in community development and participatory health research, and she coordinates a multi-center network of participatory research involving salutogenic.
I'm PAS model coordinator, and I work in the nursing school. Hello, my name is Irma. I'm PAS model coordinator, and I work in the nursing school of Coimbra. I will talk about the social benefits and challenges of health promoting university. I will make a challenge in between the model of health promoting universities stated by LT universities and the Sustainable Development Goals. I will present this in format of Pechacucha. The university is at a crossroad. The university is in a period of paradigmatic transition. In between, we face the modern problems for which there are no modern solutions, and we have not been able to fulfill the objectives so intensely advocated since the French Revolution. And in 1966, Martin Luther King says that the university must focus on the threshold social issues of our day. And this statement, it's so actual. The PAS model is a participatory management tool that engage the university to empower and apply the participatory health research. First, they must create and train a seed group and then map the health promotion projects. This group will value assets and expectation, and then they make collaborative projects to support health promotion, and more than that, to support salutogenesis. There are the countries we have already implemented. It's difficult to assess the level of implementation. So, talking about societal benefits and challenge of action research, we think that the approach and principle of participatory health research have the potential to address the insufficiencies of traditional top-down research approach, but require participatory engagement. So we will present we'll present each goal and how within the community, the academic community, we can do it, and also in the territory covered. So to ensure healthy lives and promote well-being for all, we already do a lot, monitor and promote healthy lifestyles and so on. And our students are engaged in advocate for it and the epidemics and so on. But in the other areas, there are a lot to do. So, for instance, in quality of education, the universities wants to engage students from other cultures, but they don't support them. There is a lack of this. And also about clean water and affordable and clean energy. Almost the universities could, for instance, produce clean energy to the community. And of course, the training and support students to innovative projects could be a great solution for the future. So lots of universities have already this kind of training. And of course, make cities and human settlements inclusive, safe, and resilient. This is a very strong challenge, because normally a city with the university have students problem related, like alcohol consumptions and the nightlife and so on. So it's urgent to take action. And of course, again, we can strengthen resilience and adaptive capacity to climate-related hazards and natural disasters in all campuses. But so little has been done. And to promote peaceful and inclusive societies, there is a great job to do. We need to reduce all forms of violence, corruption, and bribery, ensure responsive and inclusive and participatory engagement. And all of that, we think that between the academic community and the territory covered, we could create living labs and user engagement for innovation and sustainability. Because these living labs could be the solution to achieve the mission of the higher education institution. So, health promotion universities could lead and develop the whole system health university approach in order to achieve the sustainable goals. Because university has dynamic and complex systems with inputs, process outputs, and impacts. And we must understand each university as part of the great whole embedded in the local and global communities and interacting with the higher community. So we state that with seed groups, we could inspire examples to drive the change. And we think that there is an opportunity to start with youth and university to achieve social benefits, to achieve the sustainable goals. Thank you.
Thank you so much, Irma. And our last presenter is Michelle Baybutt, who is at the University of Central Lancashire in England, where she is an associate professor in sustainable development and justice, co-director and prisons program lead in Healthy and Sustainable Settings Unit, and the prison strand lead for Criminal Justice Partnership. She has provided regional strategic and program leadership on the development of prisons as a setting for health in the northwest of England, where she has been working for nearly 20 years. She is also the editor of the International Journal of Health Promotion and Education. Michelle has extensive health promotion and public health expertise, working with people in prisons and those with prison experience in the wider community, as well as with underserved, disadvantaged, and vulnerable groups. She is committed to improving the health and opportunities of people who are socially excluded or marginalized, and to addressing health inequities and social justice. Michelle will be sharing with us today her perspective on how prisons as a setting can serve to promote health, equity, and sustainability.
Hello, I'm Baybutt, an Associate Professor in the Healthy and Sustainable Settings Unit at the University of Central Lancashire in England. I'm delighted to be part of the IUHPE's 70th anniversary by being able to talk to you today about prisons as a setting for health, which I lead on in the unit. This presentation draws on a chapter I've co-authored with Dr. James Woodall from Leeds Beckett University, which will be available in our forthcoming handbook for settings-based health promotion, co-edited with Dr. Sami Koko from the University of Jyväskylä, Finland, and has chapter contributions from many members of the IUHPE's Global Working Group for Healthy Settings. This presentation will start by providing some background and context to the development of health promoting prisons and presenting some challenges before moving on to a case study that applies the theory of the settings approach to practice, demonstrating some examples of the opportunities of working in and with prisons in this way. Firstly, it's important to recognise, particularly in the UK context, that most people in prison do tend to come out and return to their communities, with some people moving repeatedly between both prison and community settings, which serves to emphasise the importance of prison health as a concern for broader society and public health. Secondly, it's important to acknowledge that there are a variety of people in prison aside from prisoners. So there are uniformed staff, but also external agencies who support people in prisons, such as those from drug and alcohol, accommodation and housing, and health services, as well as providers of family support and visitors centres. And there are visitors too, family and friends, but also legal visits. Therefore, prison is a setting that is both home to some people and a workplace to others. And thirdly, over 90% of prisoners across the world are male. Globally, prisoners tend to come from marginalised and socially disadvantaged sections of our societies, and they tend to exhibit disproportionately high incidence of ill health linked to social exclusion, multiple complex needs, and entrenched and intergenerational social disadvantage. Many have poor and disrupted educational experiences, are less likely to have qualifications or basic skills, experiencing low income, limited employment opportunities, low self-esteem, a lack of permanent accommodation, including homelessness, and poor relationships with family members. Many will also have experience of local authority care systems. So prisons are in a prime position to address the disproportionate health and social care issues of prisoners and offer a way of tackling inequalities in health and justice through promoting health, reducing reoffending, and facilitating community reintegration. It was suggested that the health promoting prisons concept originated from an international meeting in October 1995 with senior prison health representatives from 8 selected European countries agreeing that the public health importance of prisoner health had largely been neglected. WHO Europe then outlined its view of health promotion in prison, which was underpinned by core values such as holism, empowerment, and taking a multidisciplinary approach, and to be operationalised through the settings approach. And at the first international conference on what was then termed healthy prisons in 1996, WHO reaffirmed their commitment, stating that for too long we have overlooked the problem of health in prisons. From this, the WHO Health in Prisons programme developed a pilot network that included most of the member states of the WHO Europe region to exchange experiences in tackling health issues that face prisoners and people working in prison. WHO's principal objectives were to address prisoners' health. However, there have been some real challenges in embedding a whole prison approach.
Please turn your microphone off if it's not off.
Tendency to follow a medical model, focusing on individual lifestyle issues and choices rather than fully acknowledging the complexities of prison itself and to the circumstances which predate incarceration, as noted earlier with poverty, unemployment and fractured family circumstances. A main challenge to advancing the health promoting prison is global inactivity, and one predictor for the health promoting prisons movement was the expansion of activity beyond Europe Yet 2 decades on, since the European model was put forward, there's been very limited policy and practice, perhaps relating to resource challenges, extreme health needs, the magnitude of incarcerated populations, or a lack of political will or momentum to address the needs of prisoners. A further challenge to developing the health promoting prison is to facilitate connections with other settings, which involves marrying together different cultures and ways of working. The case study I'm about to tell you about suggests that this is possible, but it takes time to build. And navigating difficult and delicate public and political opinion as to whether prisons are deserving is ever present. So on a more positive note, here I set out an example from the northwest of England of a whole system social, therapeutic and horticultural programme, Greener on the Outside for Prison, or IUHP as it's affectionately referred to. The programme aims to reduce inequalities and achieve sustainable improvements in health and well-being, and support a reduction in reoffending rates by engaging prisoners in gardening and related activities, with an aligned programme of learning, skills development and work experience to improve employability, reduce victims of crime, connect and deliver with conservation activities, and thereby enhance environments in prison and in the local communities, and contribute to healthier and more active prison populations. There are 11 prisons involved in IUHP. Each one has a different population by gender, age and category of prison, and each prison has different types of environments, some concrete with no green space versus others with more expansive outdoor space and natural habitats. There are individual group projects that work across the individual prison, connecting with healthcare, catering, residential, gardens, external agencies, just to name a few. And each project connects to the IUHP programme at a regional level through the IUHP network. And the regional programme works closely with national health and justice partners to support a joined-up delivery of a number of agendas: food, growing, sustainability and climate action, and ecology and biodiversity, with education, learning and skills, to impact on and support health and well-being. As prisoners move between prisons, they have an opportunity to rejoin the IUHP programme in a new prison, and by doing so should further their skills, as the environment should differ and offer new and different experiences, qualifications and opportunities. Importantly, IUHP tends to work with prisoners who have high levels of complex and challenging health needs, health and social care needs, those with identified mental health problems, experiencing problems with depression and anxiety, or more challenging behaviours relating to substance misuse and self-harm, and issues with violence and aggression, or those who are struggling to integrate. IUHP is much, much more than working in and with the gardens department. For example, involving healthcare in the referral process is key, as they can undertake baseline and follow-up assessments, monitoring change over time while prisoners are involved in the IUHP project. But also connecting to different parts of the prison and the wider prison system provides opportunities for embedding an understanding of the roles and responsibilities for health in the systems and the structures of the prison setting. The consistent message from a diverse body of research suggests that contact with the natural environment improves psychological health and mental well-being. And increasing evidence suggests that nature and the outdoors is a dynamic environment that stimulates creativity and enables learning to happen faster, whilst improving health and well-being and providing an opportunity to impact positively on attitudes and self-esteem. And through robust monitoring and evaluation, the programme has shown a number of benefits. For the individual, being calmer and more stable, having more opportunities for social development and being able to work as a team, increased decision-making, self-control, increased confidence, self-esteem and hope for a different and a better future, and increasing work-related skills and learning to improve prospects for employment and post-release. And at an organisational level, building capacity through training of staff and prisoners alike, and by joining up working proving to be a more efficient way to manage limited resources, so having a positive impact on finances, for example, and having a more stable prisoner population who are focused and working are easier to manage. So in the context of the UK, IUHP offers multiple benefits and makes a significant contribution to the creation of safer, more secure, supportive and health-enhancing prison environments by embracing a socio-ecological model of health, a salutogenic orientation concerned with what creates health and enables people to thrive, and a systems perspective and a focus on holistic change. And applied in this context, the settings approach prioritises a whole prison perspective that revisits notions of control, choice and empowerment and utilises a determinants-focused framework. So ultimately, good prison health is a global concern for the whole of society, with prisoners coming from and returning to the wider community. And in summary, being able to access people in the places where they live their lives and make choices is a key public health approach. And therefore prisons are a key setting in which to intervene for both individual and wider public health benefit. And while the primary business for prisons is not necessarily promoting health, they do provide access to people who would normally be difficult to reach and engage. Prisons are therefore a key setting for health promotion to ensure health and well-being and to achieve the United Nations Sustainable Development Goals. Thank you.
Thank you, Michelle. Okay, we only have a few minutes left. I want to emphasize what Michelle said about our handbook. It's one of the products our global working group is putting out, all the people on our panel today. So I just wanted to mention our handbook. I want to remind you about the global conference taking place the 15th to the 19th of May next year, both virtually and in Montreal. And the deadline for your submission of abstracts is the 17th of September. We're almost out of time. I wanted to pose a question first to Albert, and then if the rest of you want to chime in to answer. Can you share with us, Albert, how you've overcome the barriers to working across sectors and settings? How have you been able to develop a whole systems approach to health promotion and well-being?
Okay, thank you, Marty, for the question. I think the biggest challenge is the closing down the school, lock down the community. We can't meet or interact with the student, but with advancement technology, we try to make use of the digital world. For example, how we could still conduct physical activity, interaction, and also some counseling and still holding webinar. And also under the right circumstances, we could still have a limited interaction with the school and the community and need to be more creative under the right kind of precautionary measure. If we look into the concept of open school and open community, we could create additional space for interaction, as I mentioned early on. I think we just have to grab the opportunity and monitor the situation whenever we can, and then we decide whichever mode we can, try to maintain the interaction, to avoid, even though we are physical distancing, we should not have the, I hate the use of the term social distancing. We still keep our social distance close with other modality, despite we might not be able to see one another face to face. I think that's how we try to overcome.
Okay, Mark, let me ask you, is the language that we're using to identify settings or a settings-based approach, is that an issue for us? Do we need to be thinking about perhaps using different language?
I think that's a good question, Maddie. Obviously, the concept and the terminology around settings emerged most visibly in 1986 in the Ottawa Charter for Health Promotion. So that's some 35 years ago now, I think. And it's really important, I think, that we're open to reviewing and reflecting on things and making sure that they remain current and relevant. I mean, I think the first thing to say is that I think there are some translation issues. So I think, you know, the term setting might have a different resonance in different languages just because of its translation. The second is that, you know, I'm English. Obviously, I live in the UK. I'm English speaking. Most people don't go around talking about the settings in which they spend time. It's not the most common or colloquial language. So certainly in the UK, there's been increased use of the term place-based approach. Now, I think the challenge with that is that generally when health-related systems are talking about place-based approaches, they're actually talking about geographical places. So they're talking about localities, which may be very small neighborhoods or larger geographical areas, and looking at the sort of coterminosity of boundaries between different services. Obviously, the kind of challenges and opportunities that I flagged up in my presentation, and I think other speakers also talked about, were around the importance of forging connections between settings and appreciating that actually organizational settings exist within the context of wider geographical settings. So I do think we need to be open to that. I think we need ideally to be engaging with WHO and other organizations, because it was WHO that first promoted this concept. And yeah, I think it could be a really interesting debate to look at how do we ensure that timeliness and relevance to different cultures, particularly.
And especially now that we're doing so much virtually, that started a while back, but now with COVID, there's so much. So what does a setting mean, or what does a place mean when we're talking about the whole new way we're trying to build communities?
Absolutely. And I know that there's going to be a new, really a new textbook or resource on settings-based health promotion, which Michelle Baybutt and Sami Coco have jointly edited, and that's at the editorial stage with Springer Publishing now. And I know that book will pay attention to those kind of changing dynamics, and the fact that actually virtual and online settings are increasingly, for many people, the most important forms of community and setting. So I think it's watch that space, and that book is hopefully being launched, I think, and publicized at the Montreal conference in 2022.
Yes, yes. And that's one of the products of our global working group.
Indeed.
Yeah. Irma or Albert, do you want to say anything about your approach to the terminology we're using? Irma, go ahead.
Irma first.
Oh, thank you, Albert. Yes, I agree. We need to talk about to change some language, because it's difficult to apply. In Portuguese, we use a lot of community-based or local-based, because the settings in the translation, it's context, and it's quite context, and it's not the same thing. And but yes, of course, and I must notice that the next generation of projects related with health and social well-being will be focused on that subject, community-based or family-based projects. So the engagement of the users, it's the next generation of health research, I think.
Thank you. Albert, please.
Yeah, I think in a way, follow up from Irma, we are actually talking about different communities, like the school community, working community, religious community, or even the virtual community. So I think we are actually talking about community rather than setting. I think the setting are always a difficulty, because the English used in this part of the world, the Asia Pacific setting, still could be interpreted different from people in Hong Kong, Singapore, Australia, New Zealand. And when I look at the translation and setting, not translate quite well in Chinese, Korean, Japanese. I don't know Japanese, Korean, but I heard of them saying that. So I think maybe we think about the community or the environment that people actually spending time on. I think we do need a better terminology. And I mentioned earlier on, I think we need to be, the word setting may not sound professional enough to reflect the work we are doing. That's what I want to say.
Yeah, and the context as well, because even in one particular community, things change over time. So how does the context change? And so much change with COVID. We know that the context in which people were having to live their lives changed dramatically, and especially with the schools and the universities where people could not go to work, they couldn't study. So I think that the challenges it presented us are also challenges we need to think about, and the way we rethink the way we're calling things. Okay, one last question because we're almost out of time. Irma, can you share with us your approach to what you think the interrelationship might be between governance and multi-sectoral collaboration?
Yeah, thank you. In my opinion, this collaboration depends on one big thing: the cultural, the organizational culture. Okay, and of course, if this country or if this place has a democratic philosophy or way of living, because one thing is saying that I'm a democratic institution and then not a democratic institution in a real life. So so we try to implement this bottom-up PRS model, and we learn one thing, that we need to assess the organizational culture or climate. No, not climate. I'm not sure about the real word, but culture, I think maybe. Yeah, organizational culture. We need to assess this first before begin to change anything, because if we find a very autocratic system, it's difficult to change things. And if we try to improve something, we could do damage. We could cause problems. Of course, this is like we talk in Portuguese. We have 2 points. If we find non-democratic institutions and problems and don't do nothing, yes. But there are a big challenge, and what we learn is, first we must know where we are, what kind of governance we have. But of course, as I stated in my presentation, I think the university, most of them, has the ability to do living labs. What is this living labs? It's organized like Mark said. We must stop our egos and start to work together. So most of the university have the resources and lots of advantage, lots of connections with the government to start to create living labs. And these living labs, we could do research and also increase the impact of this research to the society. And at the same time, we train students to participate on the growing of local to solve local needs and to solve local problems and to promote the growing of humanity. Because I'm a teacher in the university since long time, 35 years old, teaching in a higher education institution. And I saw more and more professionals with a big ego and not volunteering, not volunteer to help the society. And in this COVID situation, it's really, we could do better than we do. So if we engage the whole society to help the others to prevent, in the same time that we develop vaccines and so on, I think we could achieve better results than we have. So we must stop our big ego and start to work more collaborative. And this apply to researchers. We must start with us, researchers, and then to give this attitude to our students.
Great, I love it. Starting where we are and then seeing what needs to change. And I love the idea of living laboratories. It's very exciting. Mark, Albert, do you want to add anything?
Only to add to my sort of nodding head, I think that the living lab idea is really exciting and really appropriate for settings-based work, and I think for overcoming some of what some of the challenge to I suppose putting into practice some of the theory I talked about is that although settings theory has always talked about stakeholders being not just people within the settings but people outside of the setting, sometimes that is marginalized. And so I think the living lab idea can actually be a way to really engage with, if you like, real world challenges, needs, and actually bridge those barriers and connect and deliver impacts.
Thank you. Albert?
Yes, it's such great comments. I really like what Irma mentioned, also Mark early on, is let go of our ego, especially with the COVID. I can talk because being a medical person, we try not to medicalize everything, right? Now in the post-COVID situation, what we need to, how to repair the society, what we need is to respond to psychosocial need of our population. Then when you come to multi-sectorial approach, got to be someone who experienced in repairing the society, addressing the psychosocial needs of the society, to take the lead to ensure the proper governance. I think we need to have someone emerging with time, whoever could respond to pressing needs of the current situation should in a way emerge as a leadership. Then like a musical chair, you may pass on when the situation change. I think that's how the beauty of healthy setting is ever responding to the ever-changing needs of our group. Yeah.
I love that idea. So the leader today may be a collaborator tomorrow with a different leader, depending on what's happening. And the world is changing so quickly with so many issues, COVID, climate change, all kinds of things that we need to be addressing, that we need to be looking at sharing the leadership and finding new leaders. That's wonderful. Well, we've gone over our time a little bit, so I think I'm going to have to end the session. I haven't seen any questions in the chat from any of our participants, but I want to remind you that first and foremost, we have the publication that Michelle and Mark also mentioned that's coming out, that will be launched at the conference. And the conference, as I said, is taking place on the 15th to the 19th of May next year. And if you want to submit an abstract, please go online. Alexandra is showing us the site for the conference, and abstracts close on the 17th of September. So that's a few short weeks away from now. I also want to remind you that all of the people on our panel are experts in health promotion. They've been doing this work for a long time, so feel free to seek them out, to seek out their publications. And I hope you all are able to get a copy of our handbook when it comes out next year, because I think it provides a lot of new insights and things to think about in terms of moving us forward for healthy settings, health promotion, and a healthier planet. So thank you all for coming, and I look forward to maybe meeting some of you in person who I have not met before.